특별히 췌장하고 췌장의 기능을 연구할 뿐만 아니라 췌장 환자들을 직접 치료하는 의사입니다. 그리고 저하고는 굉장히 오랫동안 같이 일해왔는데 하여튼 세계적으로 유명한 이앤비 교수를 모시게 돼서 굉장히 반갑습니다.
Well, thank you so much. Today is quite an honor to be here. Thank you to Lina and to Dr. Chan and Dr. Liu for the opportunity. Yes, as said, I'm a professor of medicine at Meyiyo클리닉, and I'm consultant at the Division of Technology and Technology. So today we're going to be discussing about endothelial nitric oxide deficiency, which can be act as an upstream driver for macrovascular failure in acute pancreatitis. I have nothing to disclose. So why acute pancreatitis? Acute pancreatitis actually is one of the most common GI admissions in the United States. Every single year, there are about 270 patients in the hospital. And the incidence has been increasing globally, not just in the States. The major etiology for acute pancreatitis include gallstones, alcohol, hypertriglyceridemia, post-ERCP pancreatitis, lactation, and some genetic conditions. Luckily, most patients with pancreatitis, they present with a mild case, which means they can stay in hospital for 3 or 4 days, they can be discharged home. However, unfortunately, there are about 20 to 25 or 30% patients that become moderate to severe acute pancreatitis. And in those patients, the mortality rate can be as high as 50%. However, in clinic, it's very challenging to distinguish who will be developing a severe acute pancreatitis from mild ones. There are quite a few scoring systems available right now. However, the accuracy is not accurate at all for us to use. In the clinical practice, we have noticed that. In the practice, we have noticed two things for sure. One is the age. It's highly associated with the presence, incidence, and severity of acute pancreatitis. There are multiple large studies and the meta-analysis being shown that for patients who are older than 65 years old, their odds ratio of developing pancreatitis is 1.43. And the risk of developing severe acute pancreatitis, developing complications after admission are much higher compared to younger patients, and the mortality rate is 2.91% compared to younger patients. So because of the aging, significant association with severity of acute pancreatitis, aging has been included into multiple scoring systems for predicting of severe acute pancreatitis. Another factor which has been clearly associated with severe acute pancreatitis is obesity. And the large study have shown actually obese can increase the incidence of acute pancreatitis about 2.9 compared to lean patients. And the rate of mortality is also more than 2 times compared to lean patients. So over the past 70 years, there are a lot of advancement has been made in acute pancreatitis. However, so far there's no single target therapy for acute pancreatitis. Why is that? So over 1 decade ago, actually 1 century ago, Dr. Chiari has mentioned acute pancreatitis as an autophagus disease. Since then, there are many other mechanisms has been contributed to the family and the initiation of acute pancreatitis, which including the mitochondrial dysfunction, endothelial dysfunction, and the systemic inflammation response. However, all those targets have been targeted. There are many medications that try to target those mechanisms without satisfying clinical results. So quite some years ago, there's the proposed hypothesis that the microcirculation failure could be the key for patients who develop severe acute pancreatitis. So in a normal healthy pancreas, and there's a capillary which will provide nutrients to all the asthma cells. Asthma cells, the major cells in the pancreas. During initiation of acute pancreatitis, the leading period to the capillary will contract, which leads the blood supply to the pancreas, leading to more shots. And neutrophils can recruit and start rolling in the capillary. Then, as the pancreatitis develops, the arterial and dilate. Unfortunately, this dilation does not lead to the more blood supply to the asthma cells, but it is more shunting, which further decreases blood flow into the asthma cells, and sometimes can even cause no flow status that can further decrease the blood supply and cause necrosis in the pancreas. Additionally, the neutrophils will accumulate in the capillary and cause nephritis and thrombosis, further decrease blood flow. However, due to the location of the pancreas, which will be deep in the abdomen and behind the stomach, it's very challenging to look at the pancreas status in real time. In the past few years, there are some groups, and including our lab, we have developed an internalized immune system for the pancreas. What we did is we are able to do operation and place glass window in the pancreas and put the pancreas post window. That way we can induce the pancreatitis and start looking at the physiology and the pathophysiology in real time. So this is the first time when we did for this experiment. We use two different models. One is the CPP7PL6J mice. Those are control mice. We also use another mice called TRSS1R122 which TRSS2 mice. Those mice have the mutation of the TRSS1 gene, so they inhibit the human coagulation. Those mice, if you feed them bombazine or saline, they tend to develop into severe acute pancreatitis, compared to the B6 mice, which develop into very mild acute pancreatitis. So those are two distinct different pancreatitis models. So we keep those two models trying to understand the difference between a mild versus severe acute pancreatitis. So in the baseline, we have the yellow dye, that's the Bactrim stain. So suggesting that the dashed line is the vessel architecture. So baseline, there's some kind of change, major natural major difference at the baseline of the control and the TRSS mice. However, after we do bone messing and we look at the vessel structure at the day 2, the control mice, which develop very mild acute pancreatitis, does not have severe change in the vessel diameter. However, in the mice develop severe acute pancreatitis, you can see severe decrease of the vessel diameter. We also did a line scan trying to understand the speed of the flow in those vessels, and we use platelet as a marker for the speed. And then you can see here in control mice, the speed of the platelet actually does not decrease as it increases a little bit compared to mice who have severe acute pancreatitis. The level will decrease drastically. We also noticed actually there's significant microthrombosis developed in the severe acute pancreatitis animal models compared to the control animal models. The neutrophils, which is also important in the acute pancreatitis, we show significant recruitment in the severe acute pancreatitis cases, and you can even see aggregation of the neutrophils and the transmigration of the neutrophils into the tissue. More importantly, you can see actually the neutrophil and the platelets, they interact and form the microthrombosis, and they lead to no flow in the downstream capillaries. We further look at the few previous slides I will show you today too, and we decided to look at the earlier time points of the acute pancreatitis, and just briefly, we can see actually the vessel diameter change very rapidly after initiation of the acute pancreatitis. They start around 30 minutes after initiation of pancreatitis and sustain until 18 hours and even longer. And the blood speed also dropped significantly, starting around 30 minutes and sustain until 18 hours. Neutrophils aggregation start around 2 hours and continue until then. More importantly, actually, we distinguish two different phenomena. One is called rolling of the neutrophils, and another one is called decompletion. When we define rolling, we mean the neutrophils they start rolling around along the nuclear category, but they are not sticking to the vessels. And the right side is a total different picture. So that particular neutrophil has been stuck there for 2 minutes without moving around. So, and when the neutrophils are rolling, there is no change of the neutrophil of the blood flow. However, when the neutrophil is getting stuck at the head to the category, and there's no blood flow. So suggests that the neutrophil actually stuck is the initiation of the no flow in acute pancreatitis. So after we look at the results, we start asking the question, how can we explain the changes in both the neutrophil states as well as the vessel diameter change and the speed and velocity difference? And I was actually discussing with some of my colleagues, including Dr. Rowe, and at that time, Dr. Rowe actually introduced me to the enos regarding the nitrogen oxide. So naturally, we decided to look at that, see what we know about nitrogen oxide in this field. So in the past, about 20 years, there's some study has been done in the pancreas field with the nitrogen oxide. So this one study, particular study, show if you are blocking the NOx, the nitric oxide synthesis, you have worsening pancreatitis, as shown here by increased trypsin activity, increased the serum lipase, and the pancreas weight, the dry weight / wet weight change. So those are markers of severe pancreatitis. So if you block the NO production, you have worsening pancreatitis. More interesting, if you look at the non-specific knockout enos, but not enos or inos has significant change in the fate of acute pancreatitis, suggesting enos, but not inos or enos are the main player in the severity of acute pancreatitis. And enos is also showing actually it's important for the early blood flow increase in acute pancreatitis. So not surprisingly, we decided to try some of the enos product Dr. Chen and Dr. Lawrence provided. We are able to actually inject the NO substrate in the mice and compare after 10-12 histology mice. And this is a vehicle control. Again, it's the R122H mice. So the left side is vehicle control. The right side we use the nitrogen oxide substrate from Dr. Rowe. And we can show significant change of the morphology. In the vehicle control mice, we see the hemorrhage develop in the pancreas, but in the treated mice, we show much decreased change, the hemorrhage in those mice. And the pancreas edema is also decreased in the treated mice. Microscopic measure also look at the change of the blood flow as well as the micropulses. Very interesting. This is the baseline, and you see this is the diameter, and this is the platelet and the neutrophils just rolling along. And if we have cerulean plus nitric oxide, we don't see the stricture constriction of the vessel. We see actually mild dilation of the vessels, and the blood flow does not slow down. As a matter of fact, actually it's faster compared to control. And we still see some improvement of the neutrophils, but we don't see the stalling or the adhesion of the neutrophils this slide just summarizes the findings after a few representative studies. So remember earlier I mentioned there are two conditions lead to increased risk of acute pancreatitis incidence and increase the risk of severe acute pancreatitis, right? Obesity and aging. What are they in common? So in the aging, we know chronic inflammation and oxidative stress, they all and the enos unaccompanied will decrease the enos production, in addition to many other signal transduction pathways can decrease enol production. For obesity, the same thing. Dr. actually Mohammed has elaborated very clearly during her talk regarding how obesity can decrease the enol production in endothelial cells as well. So our hypothesis actually is convergent therapy. So we think in both obese and elderly patients, they have deficiency of the enos in their endothelial cells, which make them prone to develop acute pancreatitis and make them prone to develop severe acute pancreatitis. Okay, so our hypothesis is actually the advanced age and obesity induce the enos deficiency in the pancreatic muscle circulation. That way, they lower the threshold for capillary no flow and develop severe acute pancreatitis. So we think if we can restore the enos-derived nitric oxide signaling in Asian and obese mice or females, probably we're able to preserve the microcirculation, and we are able to meet with the early inflammation injuries and prevent the progression to the severe acute pancreatitis. So to establish that, we have three specific aims. The first one is to establish that obesity and age as drivers for pancreatic enos deficiency. So for that purpose, we're going to plan to use both the aged versus young mice and obese versus thin mice. We decided to induce pancreatitis using non-vaccine or similarly, and we're going to measure the enos expression and the activity both in the protein level and phosphorylation status. We will use the HYE system to look at the capillary blood flow, check the flux velocity, looking at the interaction between the neutrophils and the platelets, and look at the inflammatory markers in histology. So we expect to see aged mice and obese mice will have lower enos expression and activity and has worsening markers of severe acute pancreatitis. For the specific M2, we are going to confirm that enos is a payload driver for acute pancreatitis severity. What we plan to do is for the A1, the sub-A1, we are going to delete or update the enos activity either by using enos-specific knockout mice or using the loss inhibitor, and see if that can improve the severity of pancreatitis in our animal models. And the M2 will be try to supplement the NO substrate or other downstream targets to see if we can rescue the severe acute pancreatitis induced by bombacin or steroid in our animal models. And for specific M3, we are interested in looking at the specific change of the vasculature in the age/obese acute pancreatitis models. And again, we are interested in using the nitric oxide substrates and pH1 substrates, trying to understand if that can be able to rescue the animals from severe acute pancreatitis. The study has a significance in human practice. The reason I'm saying that is acute pancreatitis is a very painful disease. So it's ranked number 3. Only behind cluster headache and labor. Although some patients even claim the pain from acute pancreatitis is 3 times worse than labor pain. And so far, there's no single treatment has been approved by FDA for targeted therapy. So if we're able to use nitric oxide and treat selected patients to prevent the severity of the acute pancreatitis, we can definitely decrease the hospital stay, decrease mortality, and more importantly, decrease the complications associated with the acute pancreatitis, which include exocrine pancreas insufficiency, chronic kidney syndrome, and diabetes. Beyond that, I think this nitric oxide has the potential to be used in the future to prevent some patients from developing pancreatitis, including both those elder patients and obese patients, or patients who have some hereditary disease, which prompt them to develop severe acute pancreatitis. So with that being said, I would like to thank all my collaborators who have been helping with this study, and I also want to thank our funding